I am excited to introduce the topic that we are all here to talk about today. As we know, community health workers are the backbone of a strong primary healthcare system. We have seen this be absolutely critical right now during this global pandemic that we are all in. We have two global bodies making critical recommendations that community health workers be fairly paid for their work. The WHO recommends that community health workers receive a financial package commensurate with the demands, complexity, hours, training, and roles of their jobs. And we have the International Labor Organization recommending that community health worker pay reflect their qualifications, responsibilities, duties, and experience.
I keep on asking myself, is the government to see our work? Do they appreciate? What are they talking about our work? Or why are they taking our work for granted? Though the large number of us are women, but the thing I've realized is that some of us, we are not financially stable. We need to support our families and change the living.
The debate is over. It's fundamentally exploitative to expect the poor to volunteer as a condition of achieving their own right to health. And luckily, new research on how countries are institutionalizing CHW payment can help us as policymakers, as advocates, meet these CHW demands for recognition and for fair working conditions. So not all forms of payment are equal, and we want to look at it from the perspective of the health system and of CHWs themselves. And I should mention again that this research was undertaken by the Community Health Impact Coalition in partnership with Trust Law, which is the Thomson Reuters Foundation's legal pro bono service. And we are very grateful to the law firms on the screen for their substantial contributions to this process, again, across 5 different countries. It becomes clear, and you can see this really well in the next slide, that many common CHW payment models actually don't reflect those two key recommendations. That certain approaches to CHW compensation, particularly public sector or models with public sector wage floors, have institutionalized these recommended CHW protections. And this is relevant for ministries and planners, both to understand how certain approaches to institutionalizing CHW payment are meant to work in theory, and also, and that's what we're going to do for the remainder of this hour, dive into how they have manifested in practice.
I want us to look at these 6 scenarios, and I know we can identify with some of these scenarios from our different countries. So on the left side, where we have the red boxes, some countries are actually in the red. It is because community health workers are actually not recognized, or nor are they paid. They're not recognized as a formal cadre in the healthcare system. And so they are not paid, and they are not even recognized by the governments. And so here in this situation, what we would need is creating political will towards reform. Again, I must point out that the journey towards institutionalization is a process, and it will take political will. Political will is indispensable. So from the left side, moving towards the right, we have then community health workers who are recognized as key members of the health workforce, but they are not paid. For example, or maybe they receive some small tokens, right? For example, we have CHWs, CBVs in Zambia, or HDA volunteers in Ethiopia. That's the Health Development Army. So then for us to be able to foster pathways towards professionalization, what do we need to do? Is that one, we need to actually capitalize on emerging political will and mandate to reform, so that at least governments have now recognized these community health workers. And then we do have partners, for example, in Uganda, where we have partners such as Living Goods compensating these community health workers, giving them a stipend or something to be able to move along. So one of the key things that we need to do in this pathway is capitalize on that political will that is emerging, but also look at how do we professionalize these community health workers, their indemnification, professional associations, the way we select them, the way we train them, so that then we move to the right side of the spectrum where we have these community health workers institutionalized.
So what we have learned is to work as a team. It is all about teamwork. We've worked with our partners, we've worked together. We've worked together with the national government, the county government, and we've ensured that teamwork is in place. But very critical is that what we learned when you introduce a motion in the county assembly as the executive, it takes time to pass. But when you allow the members themselves, the honorable members themselves, to take the motion and then you support them in the technical know-how, it passes very fast. So we are grateful, and you know that we are somewhere, and all our 7,320 CHWs eventually will be remunerated.
And that was agreed, and it has been clearly documented in the guidelines for community engagement strategy. And that enabled payment of community health workers, the village health team, for the first time in Uganda, after 20 years of not being considered for any payment. But that's the starting point.
It's all about working together, but the trick is the executive to work together with the county assemblies.
As a mother, you can't see people are dying. We have to take care about them. Even in our houses, you can't just sit when there is need for help. For example, when it's, as I told me that I buy medicine daily, you can't just sit when your baby is dying. Even if it's not in your house, even in the community, even if they call at night, you have to go and check at them, because I'm a mother. Even if I'm not paid, I have to take care about them, as I've been doing.
That is a great question. And just for anyone who might not know, Samantha Power is the director of USAID at the US government under the current administration. I think if I had 5 minutes, I wouldn't want to bury the lead, and I would say, Samantha Power, we need you to use US government funds to help countries pay community health workers. One piece of evidence is that the US government's presidential malaria initiative has recently announced that it will be using that funding, PMI funding, to support payment for community health workers in countries where PMI is working. So this is a big win. This is an incredible shift. We are seeing this policy change, and I would really encourage Ambassador Power to extend that policy through all USAID funding institutions, and also use her platform to try to influence other funders, other bi- and multilateral funding institutions, to also change the way that we're incentivizing and supporting ministries of health to formalize and institutionalize payment for CHWs.